in doses that meet their own individual requirement for an adequate period of time and at lowest cost to them and to their community. When we talk of rational medicine use, it's a very complex process requiring multidisciplinary approach by healthcare professionals. So ensuring rational medicine use is not only the responsibility of pharmacists alone, but you need to ensure collaborative approach with other healthcare professionals in order to achieve rational medicine use. So these are the 6 rights of rational medicine use: right patient, right medication, right condition, right dose, right course of therapy, right cost, which we mentioned earlier. It has to be an affordable cost to the patient and the community at large. So how do we assess rational medicine use? We have been mentioning rational medicine use, rational medicine use. So you as a professional, how do you assess whether a rational medicine use is achieved or not? There are a lot of processes that you can follow in order to investigate or assess rational medicine use. One of the methods, as explained by WHO, is the WHO core drug use indicators. It assesses rational medicine use using 3 parameters. It's based on prescribing practices, patient care practices, and facility availability of medicines use policy documents. So
hello, Pharmacist Ibrahim. Your slide
yes,
is, hello, Pharmacist Ibrahim. Your slides,
yes,
your slides are not moving, please. Can you click on slideshow? Click on slideshow. Your slides are not moving. They're not moving. Click on slideshow. Yes, it's not moving. It's not moving here. Click on slideshow to move it in. Click on slideshow.
But are you sure it's not your network? Because it's moving here. It's already on slideshow.
Okay. Okay. That's the general complaint from the house.
Is there no other person with similar complaint?
Continue, please. Continue.
Okay. So we it's based on 3 indicators, as I mentioned: prescribing practices, patient care practices, and facility availability of medicine use policy documents. Prescribing practices. So there is no general agreement on the definition of rational prescribing, but it simply means an appropriateness of the whole therapeutic setup along with monitoring and feedback. So prescribing, rational prescribing process, of course, if you want to assess whether a prescription prescribing is rational, you need to have the knowledge of prescribing process. And prescribing process includes providing diagnosis. At least you have to make provision of at least provisional diagnosis, because without diagnosis, there will not be specificity in the therapeutic setup. After establishing a diagnosis, of course, there is need to state the therapeutic problems. Is it infection? Is it pain that you need to manage? That has to be stated. Then you need to define the therapeutic goals. Are you trying to bring about cure? Are you trying to manage a particular condition? Are you trying to relieve the pain? Then, of course, the therapeutic goals need to be defined. Then after defining the therapeutic goals, of course, we have drugs that will be appropriate to address each of the defined therapeutic goals. Then you have to select the class of drugs capable of meeting the defined therapeutic goals. Then from the classes, we equally have drugs with superior properties in terms of efficacy, safety, and suitability, and cost effectiveness. So you need to select a drug with superior property that can address the defined therapeutic goals. Then taking into an account of the specific patient peculiarities, select appropriate dose, routes, and course of treatment. Of course, we all know that the dose is individualized. So you have to take a particular features of your patients. Then you select the dose that will meet the individual requirement and appropriate route of administration and sufficient period that is needed to manage a particular condition. Then provide adequate information and instruction about medications, which is very, very important.
Hello.
So,
Dr. Solomon.
Which is
hello.
Which is very,
please
very...
let him stop. Let him stop and start again, please.
Okay.
Pharmacist Ibrahim.
Yes, sir.
I don't know, they say you should, it's like a generator now. Say you should switch off the engine and restart.
Okay.
The slides are static, please.
The slides are static. That's the point. And you know what? I've been static in this country. We need to move forward.
Yes, sir.
Restart the engine. Restart the engine. Off the ignition and start again.
So is it still static?
No, it's I can see another this thing now.
Okay, is it moving now?
Yes.
It's moving?
Exactly. I saw another one.
Okay.
Procedure for rational prescribing.
Okay. So
it should move to the next one so that.
So you move to the next slide for them to authenticate.
Click on, let him click on slideshow.
Click on slideshow.
I have clicked on
Dr. Ibrahim, please.
Prescribing practices. I'm on prescribing practices. Is it moving now? Or is still static?
It's still static.
Dr. Ibrahim, please. Tell him what to do, sir.
Hello?
Yes, sir.
Tell him what to do, sir.
Let him click on slideshow. Pharmacist Ryan.
Yes, sir.
Click on slideshow at the top of, you see slideshow at the top of your slide. Slideshow. Just click on it so that your slide will be bigger. Yes, just click on it. You see slideshow at the top. Click on it. No, just take your time. Click on the slideshow.
After this presentation, Bauchi State will give us 1 cow for not following on the ethics and the guidelines of presentation. This slide would have been sent beforehand so that we wouldn't be able to have these technicalities. 1 cow for them.
Still, I don't know. From here, I put it on slideshow. I don't know why the other participants are not able to view my presentation.
Well, we can see it now as a technical problem because it did not follow the guideline of sending these slides beforehand. You can continue because of time. So you can continue. At least more audible because this is 9:33 now. The presentation will be ending in next 30 minutes.
If we can't do it,
Please continue.
Okay. Well, let me share again. I don't know. So I share again, sir. Is it changing now? Hello?
Hello, please continue. Please continue.
Okay. Okay, I'm on providing adequate information and instruction about medications, then monitor adherence, and particularly for chronic condition. Sometimes when the patient comes back for refill, you can ask certain questions to assess the extent of adherence by the patient. They monitor prognosis and modify therapy where necessary. When the defined therapeutic goals are not achieved, then you can make modification to the therapeutic settings. Then monitor drug-related problems like adverse drug reaction and modify therapy where necessary. So these are the WHO prescribing indicators, which is used by some researchers to assess the impact of intervention in a particular health facility, or to compare performance of two or more health facilities. And according to this, we have like 5 indicators, prescribing indicators. Number 1 is the average number of medicine prescribed per patient encounter. And this is to check the practices of polypharmacy, which is seriously discouraged, because the more drugs you have in a prescription, the more the likelihood of interaction and adverse drug reaction. And the optimal values for WHO is 1.6 to 1.8. Then we have percentage of medicine prescribed by generic name, and this should be 100%. It is expected that 100% of prescribed drugs should be by their generic name rather than the proprietary name. Then we have percentage encounters with antibiotic prescribed, and this is to checkmate the irrational use of antibiotics. And according to WHO, the optimal value is 20.0 to 26.8. Then we have percentage encounters with injection prescribed, and the optimal values is 13.4 to 24.1. Then we have percentage of medicine prescribed from essential medicine list. We all know that essential medicines are medicines that meet the priority healthcare needs of a population. And of course, if you want to ensure rational medicine use, then the prescribed drug should be from the essential medical list or a hospital formulary. And according to WHO, all drugs prescribed should come from essential medicine lists. So we have some models to evaluate rational prescribing, and all the models are linked to 4 basic principles of biomedical ethics, like patient autonomy, beneficence, that is, it should be beneficial to the patient, and non-maleficence, it shouldn't cause any harm, justice, and veracity. These are the 4 basic principles of biomedical ethics. So even if you are using another models, apart from the one I mentioned here, like steps, then you should always remember the 4 basic principles of biomedical ethics. If there is any violation of the ethics, then you should know that there is irrationality in medication use. The first model is steps. That is, there has to be safety, tolerability, effectiveness, and cost effectiveness. The P is the price. Then simplicity. The whole therapeutic setting should be very simple. Then we have MMR. The MMR is to maximize effectiveness, minimize cost, minimize risks, and respect patient's choice. Because patient is a key player in therapeutic setting. Because if you don't carry your patient along, of course, you are going to have problem with adherence, and the therapeutic goals you want to achieve will not be possible. Then we have the ACA model. The ACA model is the appropriate patient, appropriate drug, appropriate routes, then correct dispensing and adequate monitoring. So for you to ensure rationalities in medicine use, you need to know some irrationalities. Some irrationalities in prescribing include poor choice of medicine, that is choosing a medicine that cannot address the defined therapeutic goal. Polypharmacy, we know that polypharmacy is always discouraged, or co-prescribing of interacting medicines, prescribing two medicines that interact. Another point is prescribing for a self-limiting condition, like a common cold. We know it's a viral infection, but you will see people prescribing antibiotics for common colds, and which is self-limiting. And when you see that, then of course it's an indication of irrationality. Then continuing to prescribe for longer period than necessary, prescribing underdose or overdose of medicine, prescribing without taking account of the patient's wishes. As I always say, a patient is a king, and is the main target in all therapeutic settings. So if you don't carry your patient alone in decision making, you will get it wrong there. So what are the consequences of irrational prescribing? The consequences include delay or inability to afford relief or cure of diseases, having more chances of adverse drug effects, and prolongation of hospitalization, increased morbidity and mortality, emergence of microbial resistance, financial loss to the patient and to the community, loss of patient confidence in the doctor and even the facility, lowering the health standards of patient and the community. Then perpetuation in public health problem. Because drug was not used rationally, the public health problems will continue to exist in that environment. So the next is the patient care indicators. I will just rush quickly through the patient care indicators. And according to this, we have like 5 indicators. The first one is average consultation time, which is in minutes. And according to WHO, it shouldn't be less than 10. It should be greater than or equal to 10. Then we have average dispensing time in seconds. And according to WHO, it should be greater than or equal to 90. Then we have percentage of medicine actually dispensed, which should be 100. Then percentage of medicine adequately labeled. All medicines dispensed to the client should be appropriately labeled to avoid intermixing and causing harm to the patient. Then the last is percentage of medicine, percentage of patients with knowledge of correct instruction and information about their medicine, and it should equally be 100%. Then the next is the facility-based indicator. And this is include availability of essential medicine lists, the policy medicine use documents to the healthcare practitioners. And the optimal value is all facilities should have available essential medicine list and hospital formulary. So the role of pharmacists in rational medicine use. As I said earlier, rational medicine use is a very complex process, and it covers the entire supply use chain. And pharmacists are medicine experts and custodians of medicines. And pharmacists, of course, are members of the Drugs and Therapeutic Committee, and they undertake medicine procurement. For these reasons, their role in ensuring rational medicine use cannot be overemphasized. Some of the roles of pharmacists in ensuring rational medicine use include practicing with high sense of pharmaceutical ethics, particularly the controlled drug. In order to avoid the irrational use of controlled drug, it should always be under key and lock. Then thorough validation of prescription before dispensing. And the thorough validation will give a pharmacist chance to notice any irrationality, having understood the rational prescribing process. Then ensure effective and continuous collaboration with other health professionals. We all know that pharmaceutical care is a cooperative and patient-centered system. Of course, in order to, the essence of pharmaceutical care is to ensure rational use and to achieve a definite outcome in your patient. And for you to do that, you need a lot of collaborative approach with other health professionals. Then we have proper labeling of all medicines containers to avoid intermixing that may have harmful consequences on the patients. Providing complete info, pharmacy should ensure that they provide complete information to the patient about his medication, including warnings, precaution, and unambiguous direction for use. The direction should be very, very clear without any element of ambiguity. Then another role is the pharmacy should strengthen drug information services for other health professionals. We are the expert of drugs and with adequate knowledge about drugs. So we should equally assume that responsibility. We should strengthen the drug information services. Let me share an experience with the case of artesunate injection, where some nurses will first dissolve the artesunate injection in sodium chloride, but not in the bicarbonate solution, and it will form a precipitate. They will come back to a pharmacist and tell him that this drug is not good. It has formed a precipitate. So sometimes you have to even guide them on how to reconstitute before they are convinced that it's not the drug that is having the problem, but there is problem in the reconstitution procedure. So that is very, very important. Then effective inventory management practices. Then for pharmacists to provide all these roles, you need to be a lifetime learner, because ensuring rational medicine use cannot be learned in a single lecture. It requires a repeated effort to understand the whole principle. In conclusion, medicines have equal potentials to improve quality of life or lead to harmful consequences. Ensuring rational medicine use is a key in healthcare service delivery. Rational medicine use is a complex process that requires multidimensional and interdisciplinary approach through deliberate and repeated efforts. However, pharmacist input is very significant in achieving rational medicine's use. These are my references. Thank you for listening.
Thank you so much, Pharmacist Mohammed Ningi. You tried, you did well. You've actually done justice to this presentation tonight. And we are glad it's not a highly verbose presentation where we have so much time to clear our minds and waiting for the possible end. Thank you so much, Bauchi State Rep. But Pharmacist Ningi, no, you are not, I don't know whether you are fully a member of CPAN or associate member after this presentation, because you are hired as an expatriate. The way I'm seeing it, as an expatriate, make sure you belong to CPAN as a member or associate member. I cannot stop before questions and appraisal and commendation begin to roll in. I welcome the chairman of CPAN National, Dr. Joseph Mada, the wonderful working chief scribe of CPAN, Dr. Motihat. I welcome you, ma. Welcome my secretary, Dr. Regina James. Don't be angry if I didn't put your title, because in Nigeria, title is very important in all the things we do. Welcome all the participants here in the house today. Adielo, Yebodo, Aduke, Alex, Annette from United States, welcome you. Ayodele Adediji, welcome each and you there. Welcome our strong man and one of the former CONFE chairman, Dr. Taco Daniels. I welcome you, sir. Welcome every other people that are meaningful. All the people here are VIPs. I welcome all of you. And I'm happy that we're moving forward. Be that as it may, before questions begin to roll out, appraisals and commendations, I would love, if he is in the house, the giant of CPAN, the elephant of CPAN, the life wire, the connector, a very humble man, Dr. Joseph Mado, to do his own appraisal before we can continue with the rest of the procedures and programs of this presentation. My chairman, sir, can you take over the microphone?
All right. Please, I have some network issues here, but I don't know if you can still hear me. Can you hear me well?
We can hear you, sir.
All right. God bless you, Mr. Moderator. I want to thank the presenter from CPAN and the entire members of CPAN. I'm aware of how CPAN has been going on. It's one of the state arms of CPAN that they are still at a very teething stage. I don't know what is their membership strength, but for giving us this presentation this night, assuming we have awards to give, I would have given them one this night. They have really tried so much. As I usually say, without the audience, the presenter won't have anybody. So I want to use this opportunity to thank everyone. Actually, I know it's not like a special edition of CPAN whereby everybody wants to come in through the Zoom meeting. But when I looked at the number this night, I saw about 60 something. It's still a very good number as per attendance. And I want to encourage us to keep on keeping on. Please, let's keep on encouraging other persons to join us in these clinical meetings, because this is our strength, this is our tool. Without updating yourself, or the moment you stop learning, you start dying. So for pharmacy to move forward in this country, we need to keep on learning. Just like as the presenter said, rational drug use is not something you can learn all in a single lecture. And I know that as we keep on attending different lectures, we'll always be getting little points that build us as experts, and we can always take this to our places of practice. Of course, what is currently happening in CPAN, if I'm an outsider, I would have envied CPAN. We may not be going to the wards as pharmacists, but even with the lectures where we just keep on updating. And I'm looking for a way, by God's grace, that very soon we shall be giving continuing education points. Once we are able to fashion that out, because we know there is no way you will have been attending these clinical meetings and remain the same. You will be one of the best pharmacists in the world. On that note, let me once again congratulate CPAN, congratulate the moderator and all the attendees. God bless us all. Thank you very much.
Thank you so much, my chairman. He has actually hit the nail on the head. And for us to know, I keep on saying, well, we are the drug expert. If you hand over a drug, maybe like sildenafil, for a patient in a management of pulmonary hypertension and say, take this drug one daily, you have failed as a pharmacist. Try to let the patient know that while on the course of this drug, he or she might witness something like pains, and these pains need to be managed. If the patient is a pulmonary hypertensive patient, and the physician goes about by prescribing an NSAID to counter the pain, you will be able to know that it's not a right way for rational drug use. Why? Because the sildenafil works by releasing the pro-inflammatory mediator called nitric oxide to work. And if you use an NSAID, NSAID will block the activity of nitric oxide and the drug will not give results. So if you are thinking on what to do, you think about some drugs, alpha-2 prenational pathway drugs, like Cenarizine, drugs like popularly called Sedalud, which will be able to help even in regulating the hypertension and equally stop the pains. Ladies and gentlemen, the hall is open, but remember and know it that any drug you give to patient must have an instruction, whether it's paracetamol, whether it's vitamin C, take with food or take after food is necessary. That is a reminder to the patient that you are not a technician or ordinary drug giver, that you are a specialist. So ladies and gentlemen, the house is open for appraisals, commendations, and contributions. Hello, distinguished colleagues. Hello, presenter from Ningi.
Yes, sir, I can hear you.
It looks like they have given you a nod in what you presented. It's like they don't want to ask you questions or appraise your work. But thank God the chairman of CPAN has actually appraised their work. Or maybe majority of people might be thinking that this has been a routine of talking about rational drug use. Well, I must actually commend you. You did well. Just like I said beforehand, that you acted like an expatriate you are, and you did justice to the topic. But beforehand, there is a hand up, and is an able secretary to this, to the committee of CPAN, Education Committee of CPAN. Her name is Dr. James Emana Basin. Regina, we do respect, ma. Can you go ahead and do justice to why you are raising the hands? Maybe after this, we might have some dollars coming from the oil headquarters of Akwa Ibom Kingdom. Go ahead, man. Hello, ma, are you there? Go ahead. Hello. Pharmacist Ifoma Moma, are you there? If you are there, you can continue, but I'm not giving you a chance to overtake my secretary. But the point, like, you can continue until when secretary finds out what is wrong with her connections to the central house, so the control room. Go ahead.
Please, sorry, it was a mistake. Oh, please, sorry, it was a mistake, please.
No problem. Raise your hand. Raise your hand down now. Or do you want slap? There is a slap going on now.
It was a mistake, please, sorry.
They will just give people slap for just getting up from the seat and talking. It was bam, slap. So we don't want slap in CPAN.
I'm sorry.
Dr. Timmy Prayer Okro IPCC. Can you take over, ma? Can you take over?
Good evening, Dr. Solomon. Good evening, the wonderful presenter from Bauchi. I really want to say thank you, Bauchi presenter, just the way the national chairman said. Bauchi really has been, there was a time we were actually looking for a presenter from there. We are happy to see that today there is a presenter, but I just noted just the way the moderator also noted. I want to encourage you, our wonderful presenter. I don't know you because you are a pharmacologist. You are tending towards being a pharmacologist. I can see that you are a lecturer at the College of Health Technology, and then you are going into your MSc pharmacology in view. You've done something on your postgraduate diploma earlier. So I just wanted to ask a way of question. You are lecturing. Is there any connection with what you are doing apart from this knowledge that you have just given to us? Do you have any other experience, maybe in the hospital or probably in a community setting? I was trying to look at your background. I don't know whether you are in a community, you are in your premises. Does that look like a premise? Presenter, are you there?
Yes, ma'am. Thank you very much. Can you hear me?
Yes, I can. I'm hearing you.
Yes. Of course, I have a lot of experience in community pharmacy, and in fact, even the lecturing in the college, I was withdrawn from facility. I was once the pharmacist in charge of General Hospital, Al-Galeri, along on the road. So I was withdrawn from there to go and pioneer pharmacy technician program at College of Health Technology in India, and I did that.
Wow, thank you very much. You see, why I'm asking all this, we normally put all this down during the advertisement. I don't know why the advert this time just got just a brief, just saying that you are a lecturer. Thank you so much. We are very happy to have you and want to encourage Bauchi. We want more of you on this team. You can also register as an associate member. I don't know if you have any clinical certificate. You can come in and as an associate member of the CPAN.
Yes, ma'am.
If you know what I mean. I don't know whether you need
what I have, the clinical certificate I have is for an online courses, not from a recognized institution here in Nigeria.
It's okay. Thank you so much. We really enjoy your presentation, and we hope to see more of you.
Thank you.
Thank you.
Thank you, IPCC. My secretary, are you around now, Dr. James Regina Manabase, are you around?
Yes, good evening, my chairman.
Thank you. You're welcome, ma'am.
What I wanted to say, I appreciate the presenter. And then I want to encourage us all as clinical pharmacists. I believe that rational use of medicine is really our responsibility, whether in the hospital or in the community practice. But like now, there's so much of self-medication where patients just come in, they just prescribe for themselves. In fact, they diagnose and prescribe for themselves. And I believe it is our responsibility to guide the self-medication. I find some people that will come there, they want half card of ampiclos because they have rashes or they have itching and all those things. I think it is an area we really have to go into and ensure the rational use of some of these medications. Like antibiotics, we discover there's so much resistance because of irrational use. The same thing goes with the NSAID and many other medication. I think we should really give it much attention to ensure the proper use, rational use of medication wherever we find ourselves. That is just the encouragement I want to give to all of us. Thank you and good evening, distinguished pharmacists.
Thank you so much, man. That is wonderful. Very soon, we will develop a blueprint to start slapping those pharmacies that don't want to do the right thing. So house is a good one. There is one technopova. Please don't be angry if I don't call you up to start speaking immediately. I cannot keep Dr. Otako Daniel Orumese waiting. He was the former chairman of Comfy. That does not mean you are not a VIP. You are. But at this juncture, kindly permit me to introduce to the house Dr. Otako Daniel Orumese to do his appraisal contributions or questions. Dr. Orumese, sir.
Yeah, thank you. Good evening, everybody. I have listened to the presentation with rapt attention, and I want to congratulate the presenter and to congratulate CPAN on this giant stride. However, I believe that I need to share a few perspectives. We're talking about rational drug use in Nigeria within the context of the present situations that we find ourselves in reality. First, let's look at the provisions in the National Drug Policy. It talks about rational drug use, particularly with respect to institutional prescribing. In some sections of it, where it says, where there is a prescribing doctor, there will be a dispensing pharmacist, and the roles were clearly spelled out. The same National Drug Policy also provides for self-medication. And it basically also says that in those areas where we have sufficient knowledge, the same National Drug Policy prescribes and provides for patent medicine, vendor's license, and all of that. Now, my thinking and my worry is that if we look at all of this within proper perspectives and with the reality in Nigeria, where 99% of the private health facilities, hospitals and clinics do not have pharmacists or even pharmaceutical personnel to ensure that prescriptions are even vetted in the first place. How do we ensure rational drug use in those areas? That's one. Two, for those who find themselves in patent medicine shops, how do they employ, or how do they get themselves to understand what is rational drug use? Having said that, gentlemen, I think that for us to be able to get this issue of rational drug use, we need a lot of advocacy. We need a lot of publicity. We need a lot of publications. We need a lot of enlightenment to the public to make them understand that drugs are not articles of food, neither are they just articles of trade, and that they can get harm from it by not using it properly. And that the only person, the only professional who can stand in as a bridge between them and harm is a pharmacist. Only then can we ensure rational drug use. For those who are in the tertiary hospital, to some extent, yes, we're encouraging rational drug use because it's institutional prescribing, institutional dispensing, and all of that. But at the level of the community, of the society generally, we need to do a lot more work. Even our colleagues in the community pharmacy, except you find a pharmacist there 247, or let me never say 247, at least for a good number of hours during the day, and the practice has semblance of practice, not selling, then of course we can be talking about rational drug use. So I think that we need to look at the possibility of embarking on an enlightenment campaign, pharmaceutical education, health education, to educate the public generally on this issue. And when we do that, I believe that all the advantages that come with rational drug use will be properly harnessed, and then the people will benefit from it. So once again, I want to thank you for giving me the opportunity to speak, to share my perspectives. I also want to thank the presenter, and I want to thank the entire members of CPAN, and to say that let's keep doing what we need to do. Let's keep trying our best, even in our very little areas of influence where we are presiding. And I think that the tomorrow definitely will be better than today. Thank you very much, and God bless all of us.
Thank you, sir. Thank you, sir.
Thank you, sir.
The user of Technopovanio,
I'm done with my presentation.
Thank you, sir. Technopovanio, can you step in? The pharmacy is using Technopovanio. Can you step in?
Mr. Moderator, can you hear me?
I can hear you, sir.
Hello?
I can hear you, sir, loud and clear.
Hello?
Hello, I can hear you. I can hear you.
Hello, Moderator.
I can hear you, sir.
Crystal has not been answered.
I can hear you.
His question
Okay.
has not been answered,
Hello.
moderator.
Okay, no problem. I can hear you, sir.
Hello, good evening. Can you hear me?
Yes, we can.
We can hear you loud and clear.
Can you hear me now? Hello.
Hello, good evening.
Go ahead, sir. Go ahead.
Dr. Dan still wants to talk. Oh.
Good evening, sir.
Yeah, good
Go
evening.
ahead,
Yes.
we can hear you.
Okay, I'm the user of Techno of a new.
Okay.
I'm pharmacist Yusuf Abubakar Muhammad from Bauchi,
You're welcome,
an
sir.
associate member of CPAN.
That is
Can
nice.
you
You're
hear me,
welcome,
sir?
We can, sir. We
That's
can.
good. So, in the first place, I have to congratulate or to show my appreciation to moderator for coming and coordinating the house, most especially from the beginning of the presentation. Secondly, the presenter, we have to also appreciate his effort and also composure, especially during the beginning of presentation. Actually, this is just a few one of the short clinical presentation that I was opportune to attend. But I'm so happy. I'm so I enjoy how the presentation is going on and how people are contributing. One important thing to what I want to add based on this rational use of drug is very, very relevant to all pharmacies. I think this topic is very broad and also very important. When a pharmacist knows how to use this term or know how to make this term rational use of medicine is the only thing that can differentiate pharmacists from other professionals or other non-pharmacists, even in the healthcare professions. At this point, I think the presenter has done justice to the presentation and also the audience. I'm so happy, I'm so glad to understand that everyone was calm, no choirs, no any making noise, no more disturbance based on the how the presentation, the slide was so disappointing from the beginning of this presentation. I'm so grateful on behalf of all Bauchi pharmacists and also the presenter. We are so happy and we promise you your cow, as the moderator made mention earlier. We are on that. When we are hosting the CPAN National Convention, don't forget to remind us of that your cow, because we don't know how to share cow. I hope you understand. Thank you. I'm so grateful for that. And this thing is, I'm so happy. It also not only to educate pharmacists, but can also bring more national unity among the pharmacists and even non-pharmacists or to the nation at large. I'm so grateful. Thank you very much. Have a nice day to all of the members of the House. Thank you.
Thank you, sir. That is wonderful.
Moderator,
and
moderator, we will need the cow in Jos. We need the cow in Jos. Yes, during PSN conference.
No problem. I'm going to write a secret letter and increase the number of cows. Thank you, sir.
Thank you.
Let me quickly welcome my auntie and one of the super maker of pharmacy profession in Nigeria, a very peacemaking woman, very resilient in everything she does. Dr. Obianuji Onwategu, we are welcome, ma. All the pharmacists in the house, La Victoria Wanko, you're welcome. Stella Foy, you're welcome. Rosaria Wemi, you're welcome. Dr. Raymond Kechuku, you're welcome, sir. Queen Fasami, you're welcome. Princess Onwuchekwa, you're welcome. Pharmacist Aneke Monde, you're welcome. You're welcome, Olumide Soyemi. Olufemi Fafiola, Okwala Anselm, Nuruddin Usman, Nkiruka Mwebodo. Dr. Maureen Mwapa, our Airborne National Vice Chairman, you're welcome. Michael Sua Ewuga John, you're welcome. Jimo Ezekiel, Ifoma Momo, Ibrahim Bello, Ibrahim Abbas, Halima Abdullahi Jero, Hakim, all of people are welcome. Dr. Polycarp Epe, the Dex Officer of Pharmacists Nigeria, you're welcome. Welcome everybody here present, Kalabi Fami Chiwonyeka, Awao Sadiq, Aduke Akinsekwe, Alex Meseko, all of people are welcome. At this juncture, I am calling my secretary, the secretary of CPAN Education Committee, Dr. Regina James Emana Abasi, to do a vote of thanks and equally do a closing prayer. But before then, we'll remember that the next state that we're presenting in 1st of April, and I will be very glad so that person will not do us April Fool, is Jigawa State. And I am confident enough, and I'm particularly happy because the person that knows how to do organization and administration very well, our erudite chief scribe, Dr. Motihadu Lulawal, is the one that will be moderating on that day. That is 1st April. So the Jigawa State will be preparing so that they send their slides on time for us to do our prayers and make sure that we'll get it much better as the band grows. Thank you, House, as I welcome my secretary to do the justice to the closing remarks and equally do a closing prayer. Dr. Regina James Emana Abasi, take over, ma, and conclude the section.
Thank you very much, my chairman. We really appreciate the presenter and the participants. Like our national chairman says, without the participant, there would have been no presentation. So we appreciate you all, very distinguished colleagues. Thank you for coming. And I want to remind you that this clinical meeting holds every Friday by 9 p.m. Please come along with us. And like the chairman said, so that we can update our knowledge in clinical pharmacy continuously. On this note, I'll take the closing prayer. Heavenly Father, we thank you for this privilege to learn in order to serve humanity. We thank you, dear Lord, for CPAN, for this training. Help us, Lord, as we learn, to implement it, to improve the life of the public in Nigeria. In Jesus' name. Amen.
Amen. Thank you, ma.
Amen.
Good night,
Amen.
everybody.
Amen.
Good
Good
night.
night, everybody.
Right.
Good night, everybody.
Good night, everyone.
Good
Have
night.
a
Good night,
lovely weekend.
In Jos.
Good night, everyone.
Good night to everyone.
Thank you.
Congratulations. But they really tried.
Ibrahim.
Receive one slap from Bauchi. So good night, everyone. Thank you so much.
Ibrahim, kaje mana sani mu.
Okay.
Kaje mana sani mu Ibrahim. Thank you very much.
Okay, Pharmacist Ibrahim, can you send it the slide to the Solomon? Pharmacist Ibrahim.
Okay, sir. Yes, I will send, sir. I will send.
Well done.
Thank you. Well done, sir.